আজকে মেইন ক্লাস যেটা হচ্ছে শক। তাহলে প্রথমে জানতে হবে হোয়াট ইজ শক। এবার শক এমন একটা টপিক যেটা it will come in your medicine, it will come in your surgery, and to a limited extent in orthopedics. Shock is a very important topic considering, ঠিক আছে, তো we'll try to give a overview of the topic. So what is shock? Shock is a condition or a physical stress that arises because of a hypoperfusion to the important tissues. So what do you mean by hypoperfusion? Hypoperfusion means it can be either because of reduced oxygen supply, it can be either because of a reduced blood supply, and what it results is that there is either a reduction in the cardiac output or effective circulatory blood volume. So the main thing of a shock is a state of a physical emergency. So it can arise out of very many causes, and accordingly of the causes we classify the shock into different types. But it is basically as an emergency cause where it's more of a stress that causes a physiological change, that demands a physiological change in your body, which is manifested by a lot of things. It will first come as a hypotension, then it will become as a hypovolemia condition. There will be a increased state of cardiac output. The heart will try to pump the blood, but it will not be going to your extremities because all the blood will be shunted to the important organs like the brain, the kidney, which always demands more blood. So there is a cascade of things that happen. So first are hypotension. Then what happens is tissue hypoperfusion. So first your extremities like the skin, the end of the nails, your toes, those will become cold and clammy because your body redirects the entire blood to the more important organs like the brain, the kidney. So they will demand more blood. So it starts as tissue hypoperfusion, which starts from the extremities, and that will be the initial stages of shock. Body will try to get it back to its normal physiological state. But suppose the insult, the physiological insult that has started this condition continues to go on, then your stages of shock also progresses, like stage 1, stage 2, I will come to that. So after the tissue hypoperfusion, what happens is cellular hypoxia. You guys have read in pathology, right? So what is cellular hypoxia? So when the tissue doesn't get enough oxygen, the oxygen content in your tissues or the cells goes down and the cells are deprived of oxygen. So that condition is a cellular hypoxia. Now at this stage, this is considered as a reversible injury, means the cell is still viable, the body is trying to fight. If someone who is seeing the patient or the appropriate conditions or appropriate management is given, you can still revive the cell. So it is not going to die. So that is the stage of a reversible injury. But suppose if it is still not corrected and the insult or the initial insult that has resulted in this condition continues to persist, then you will lead into an irreversible injury with a persistence of shock. And that is the problem when everything comes to shut down. Then even your heart cannot supply the oxygen, your multiple organs starts failing, and then you are landed up in a condition called MODS, multi-organ dysfunction syndrome. So this is your entire cascade of shock. So basically what is a shock? It is a physiological insult or a physiological response to an external insult to the body that results in a series of physiological changes resulting in either a complete recovery or an irreversible damage depending upon what condition the body has been subjected to. So that is the basic thing that I want to tell you. So there are a lot of types of shock, that was I was telling you. It can happen because of many causes. It can be suppose a person meets up with a road accident, has an open femur fracture, has an internal abdominal injury, so that results in a lot of blood loss. That is what is called a hypovolemic shock. Suppose a patient is subjected to 3rd-degree burns, skin burns, lot of fluid goes off. That is also a hypovolemic shock. So that is what is called a hypovolemic shock. Cardiogenic shock, I will just be talking in brief because it has no aspect of it comes in orthopedics. But you guys might be reading it in medicine when you go. So that is a condition where there is a reduced cardiac output because of many causes. Maybe a ischemic heart disease, maybe a cardiac arrest because of that. But that has nothing to do with orthopedics, so I am not going to details in that. Septic shock, very important thing. when it comes to orthopedics. Because there will be by many patients, if you have seen a condition called as septic arthritis or a patient in septicemia, localized infection that was, see, always body has its natural defense mechanism. It always tries to fight infection. Many of you have even got a small boil or acne. These are all small inflammatory changes. But it usually resolves on its own. You don't need to do anything extra for that. But in certain conditions, like if you are seeing an immunocompromised patient, or if he is a diabetic patient, uncontrolled diabetics, the body's defense mechanism is not able to cope up with the amount of inflammatory response or the stress that has to come. Now again, this is pathology. So the basic building thing is your pathology, first year subjects. You have to know what are the neutrophils doing, what is the complement, what is the cascade pathway. So everything that is the basic pathology and physiology is your first year subjects, first and second year subjects. So septic shock is a condition where the inflammatory responses, when it goes beyond the body's physiological control, that again results in a cascade of things. This again results in a increased, if there is an increased leukotriene activity, if there is an increased complement cascade. So what will happen, if you remember your pathology days, you will remember of a condition called DIC, disseminated intravascular coagulation. So when everything starts to go up, then it starts a condition of DIC. And DIC is a pathway to again go into MODS, multi-organ dysfunction syndrome. So that is how a septic shock is again dangerous. Anaphylactic shock. So many of you might have even a bee sting, and you might be having a acute phase where you will have a shortening of breath. Okay, this is not actually related to orthopedics. I am just telling it because of the completion sake, because these are the types of shock that you should know. Okay. And lastly, neurogenic shock. Now this is again very important in orthopedics. Suppose you see a patient with a road traffic accident, high velocity injury, a blunt injury or a penetrating injury to the spine. If you guys remember, there was something in physiology called the sympathetic outflow. Do you remember? Right? Sympathetic outflow. So this sympathetic chain is a very interesting thing, because this has control to the heart. If you remember, it increases the heartbeat, it increases the blood pressure, so like that. But when it gets injured, the sympathetic chain up to has the level of T6 vertebrae. If you remember, it has up to T6, T1 to T6. So any injury within that region, it will cause a disruption in that sympathetic outflow. And when that sympathetic outflow is disrupted, then your body will have trouble maintaining that cardiac output, maintaining that heart rate, and then everything will fall. So that is the condition which is called as a neurogenic shock. Now there are two terms in orthopedics with spinal shock, I mean related to the spine. One is neurogenic shock, another is spinal shock. Spinal shock is totally different. So I won't be talking in context with this. But neurogenic shock, I am talking here because it has something to do with the physiological blood flow, and it is related because when you have an injury which is up to the level of T6 vertebra, if anything is around this region, T1 to T6, you are very prone to get this kind of patients. And this kind of patients will come to you with, hypovolemia, reduced heart rate, cold clammy extremities, and that is important to differentiate that whether the patient is in a neurogenic shock or in a hypovolemic shock. Because if you can't differentiate and then considering your hypovolemic shock, you start administering fluids, then you will be in trouble. Because then it will lead to ARDS in the lungs, excess fluid overload, and then your lungs will be drowned in water. Okay, so that is important. So you need to, so very important thing to see for shock is the history. You have to know history. What has led to this condition? What is causing this condition? If there is a road traffic accident, like most of the times that happens in our orthopedic field, is a road traffic accident. So you have to see whether there is any open injury. Most important thing that is missed are closed injuries to the abdomen. So you cannot always rule out closed injuries, blunt trauma to the abdomen, because those are very important factors. You might not see bleed, but you will be shocked to know almost 1.5 to 2 liters of blood may be lost inside this, and that is enough to cause a phase of a shock. Okay, So that I will be speaking in the stages of hypovolemic shock. So let's move on. So this is a graphic depiction. See on the right side, hypovolemic, think low volume. The volume will be low, okay? So when there is a severe blood loss or a fluid loss, okay? Fluid loss you can see in many conditions. I can say in burns, in severe diarrhea, severe dehydration. So all this results in hypovolemic shock, not always in trauma. But as we are considering orthopedic, so I will be sticking to just the orthopedic part, okay? Septic shock, widespread infections and sepsis. Anaphylactic shock, see, from foods, medications, insect bites. Neurogenic shock when a spinal cord injury or damage to the nervous system. See, they have marked that picture. If you see the bracket, it is only highlighting the thoracic spine. So that is the characteristic. If there is a lumbar spine injury, you are unlikely to get a neurogenic shock. You might get a spinal shock, that is separate thing, but not a neurogenic shock. Because the basic idea of neurogenic shock is a disruption in the sympathetic outflow. So that you have to remember. But spinal shock is different. Spinal shock is totally different. That is a total loss of axonal outflow because that causes damage to the spinal cord. That is a separate thing, but not same as neurogenic shock. So we can discuss it later. And cardiogenic shock, this is important for medicine, but not at all important for orthopedic part. So let's come to the most important part of orthopedics, which we deal almost every day, is a hypovolemic shock. So it occurs due to a rapid reduction in the blood volume or plasma volume. What are the causes? It can be hemorrhage, it can be severe dehydration, burns, abdominal ascites, pancreatitis, diabetes, overuse of diuretics. But in orthopedic field, we'll stick only to massive blood loss, open trauma, closed abdominal injuries, mainly that things. So this slide is very important, see. Now, this is actually what is important for shock in orthopedics, because almost every day we see patients which comes with different grades of shock. And that is totally, clinically what you are going to see, that is going to decide what kind of treatment we are going to give to the patient. So how to decide what stage? So this is important slide, see. So how many of you guys watch tennis? Anyone watches tennis? No one? Okay. But do you remember the scoring system of tennis? It starts with 0, 15, 30, 40, advantage, deuce, game over. So the same thing. So if you are a tennis fan, so you will be remembering this very easily. See, blood loss 15%, up to 15% class 1, 15 to 30% class 2, 30 to 40% class 3, and if it is 40%, it is game over. You cannot, it is very, very difficult to revive the patient from a stage 4 shock when there is almost 40% blood loss, okay? So 750 ml, less than 750, that's in ml, okay? Up to 750 ml, a 15% blood loss, 750 to 1500 ml blood loss is class 2, 1.5 liter to 2 liter of blood loss is class 3, and anything above 2 liter, it's actually practically a very difficult scenario to revive the patient, because that patient demands massive blood transfusion. And considering our setup to get the patient, to get the blood, to get the cross match done, to have that blood given, it's actually a difficult situation. And in that situation, just giving fluids is not going to be enough to save the life of the patient, okay? So next important topic, see what is written, heart rate. That is the heart rate. So in class 1 shock, what happens? Initially, your heart rate will reduce, that is less than 100. So when it is less than 100, the class 1 is totally a reversible thing, and in class 1 shock, majority of the patients, they tend to get better on their themselves. The physiology is like that. They will try to get it better on themselves. So the heart rate is less than 100 beats per minute. BP will be normal. Pulse pressure. You remember the definition of pulse pressure, right, from physiology? Yeah. Respiratory rate will be normal. Urine output will be more than 30 milliliter per kg per hour. That is urine output, okay? And if you are looking at the neurological status of the patient will be absolutely conscious. He will be very, very well oriented, but might be a little bit of anxiousness. So that is when you lose blood but not that much. That means the body is trying to get it back. Okay. Problem starts from class 2 shock. Class 2 shock means you already have lost around 1 liter of blood or fluid somehow. And that's the majority of the cases that we get. When open injuries, class 2 are the most common open trauma cases that comes in orthopedics. So what happens in class 2? So if you are classically seeing these class 2 patients, what will happen? The pulse will be more. They will be tachycardic. That means the heart is trying to compensate. The heart is trying to increase the amount of blood because it wants the important blood to be shunted from the peripheral organs to the important organs. Because your brain cannot survive a second without blood. That is the most important thing. So it will be shunting the entire blood from the extremities to the brain. Next important organ, lungs, kidneys. So that will be shunted over there, and that's why your heart rate will start to increase. Your BP will still be normal, but what happens? Your pulse pressure starts to decrease. So I mean, the pulse pressure is the gap between the systolic and the diastolic blood pressure, right? And in this kind of shock, your systolic starts to fall. And you will have, if you go on measuring the BP, it will be somewhere around 90, 60, 80, 60. Pulse will be somewhere around 120. So that is the point you have to identify, okay, this patient is in shock. I need to do something. You need to do something. Otherwise, it is not going to come back on its own. Now, grade 1 shock, stage 1, it usually gets better on its own because body's physiology works like that. If you remember from the physiology days, like there were a lot of things like the baroreceptors, carotid body receptors. So those will try to come into play and they will actually get it done. But in class 2, you have to come into something. Okay? The respiratory rates now starts increasing. It comes to 20 to 30 per minute. Urine output starts to fall below 30, up to 20 to 30. Okay? And now the patient is mildly anxious, but actually some bit they also become disoriented also. Okay? Class 3 shock. Class 3 shock means the patient has already lost over 1.5 liters of blood. Okay? So that is almost 30 to 40%. This is also seen in orthopedics, but now this patient, if it comes to you in emergency, you have to act very fast. So the heart rate is way above 120, the blood pressure starts to decrease, your pulse pressure starts to decrease, your respiratory rate increases a lot, and the urine output also reduces. Now the urine output is actually a measure of the kidney function. Now if your urine starts to decrease, then all the toxic metabolites that will not be excreted from your body starts increasing. Your urea, creatinine, everything starts to increase. And then you will land up in a condition called acute kidney injury. And that leads to a cascade, then it results in a multi-organ dysfunction syndrome. Okay? So that is what exactly happens in class 4. Because class 4, even if you revive, there will be a lot of other complications that will take place. Your kidney is not functioning properly, you are already in the stage of kidney damage. You need a lot of blood transfusion, and that can lead to a lot of issues. So you need to know the massive transfusion protocol, which is 1:1:1 PRBC you have to give platelets, you have to give whole blood, plasma, everything you have to give. You cannot just transfuse whole PRBCs to the patient, because then your platelets will also start to fall, and then it will again lead to a cascade called DIC. So managing a stage 4 shock patient is actually very difficult. You will try to correct the volume, something else will go wrong. So now that is the issue with the patients. Okay, so this side is clear. Okay, take a photo of this because this is very important. If you have not taken, take a photo if you want. So hypovolemic shock, what is the pathophysiology? There is a loss of volume either by dehydration or by fluid loss. Reduction in the intravascular blood volume, there is a decreased preload, there is a decreased stroke volume and the cardiac output. There is a systemic hypoperfusion, there is compensatory vasoconstriction. I mean, if your blood is not going, what will be your blood vessels trying to do? It will try to decrease the caliber so that your blood stays more over there and there is adequate perfusion. But when there is constriction, the warmth in the fingers will go off, and then you will find cold, clammy extremities. That was I was telling previously. So that are the hallmarks of a shock patient. You will have cold, clammy extremities. You cannot feel the pulse volume. You might feel a tachycardic pulse, but the bounding pulse won't be there. The volume will be reduced because the cardiac output is reduced, and it tries to preserve that energy, shift the maximum of the blood to the major organs. So those are the things that are going to be there. See, tissue ischemia, hypoxia, cellular and organ dysfunction in the late stage. So that are the basics of hypovolemic shock. Now coming to cardiogenic shock, not needed for orthopedics, absolutely not needed, might be important for some cases of your medicine. So I'll just be going quickly through it. It is characterized by reduced pumping ability of the heart due to intrinsic myocardial damage or extrinsic damage or obstruction to the outflow. Very good example of it is a ischemic heart disease. Okay. So cardiogenic shock occurs in 8.6% patients with ST segment elevation. Again, ST segment elevation you get in a ischemic heart disease when you have a cardiac arrest or a heart attack, commonly which you call ST elevation. Okay. So causes of cardiogenic shock, see, the most important and the very common thing is myocardial infarction, MI. Then you have valvular regurgitation, acute myocarditis. You can read it down. So not related anything to orthopedics. Okay. So septic shock. So this is important. So in orthopedics, 3 shocks are important. You have to know about hypovolemic shock. Hypovolemic shock is important throughout your life, whichever stream of medical field you are going, medicine, surgery, orthopedics, you have to know this. Because you have to identify what stage the patient is in and what has to be the management. Okay, management I will come to it. So septic shock is a clinical state that accompanies infection either confined to a local site from which the toxin are absorbed or associated with invasion of the organisms in the bloodstream. Okay. So what are the causes when there is a localized infection and it starts spreading? Very, very common example or common cause of a septic shock is a septic arthritis. So in orthopedics, we often get a septic arthritis, especially in immunocompromised patients, diabetic patients, patients on long-term steroid therapy. So septic arthritis is a localized infection that happens inside the joint, but sometimes can be disseminated into the body because of many causes. And one of the main causes is induced by the orthopedic surgeon is putting in a needle, trying to aspirate it, and when you're doing that, you are disseminating the infection. So you have to take proper protocol. You have to give proper antibiotic coverage while doing it. You have to take certain precautions also. Okay. So causes of septic shock: microbial infection, gram-positive septicemia, endotoxic shock, fungal sepsis, superantigens. So what are the predisposing factors? So you need to know what are the high-risk patients actually. So advanced stage, long-term illness, increased use of invasive procedure, disseminated malignancy, increased number of immunocompromised host. It can be due to secondary to malignancy, immunosuppression, HIV infection. So basically you have an immunocompromised or suppressed host, or patient who has a very poor nutrition, advanced stage, where the body's immunity is not able to fight the infection. So those are the cases where you get a more tendency to get this infection disseminated into the body. And when this dissemination goes inside the body, what it does is this. So all this complement starts getting activated. You remember the cytokines, right? You remember the complement cascades. So when this starts activating, the endothelial lining of your vessels get damaged, and that results in more amount of platelets to be used up, more amount of leukotriene activity, more amount of complement activation, and this cycle continues. And then finally it will result in a DIC. Now once a DIC happens, so what happens is there is extravascular fibrin inflammation, vascular occlusion by the fibrin, inflammatory response, and when all this happens, there is hypoxia is bound to happen. Your tissue is not going to get oxygen. And when this happens, then you are left with nothing but an MODs. So the physiology again becomes the same. So there is a tissue hypoperfusion, there is a hypoxia, and then you land up in MODs. Neurogenic shock. Neurogenic shock occurs in a setting of an accident or a spinal cord injury that causes loss of vascular tone and peripheral pooling of the blood. Sympathetic tone that I was talking of. So the sympathetic tone is very important because it increases your heart rate. It causes vasoconstriction of the peripheral blood vessels, and that is important because that is very, very important to maintain the blood supply to the important organs. So if that is gone, you are in trouble. And then you have to identify that, because neurogenic shock sometimes very closely resembles to an hypovolemic shock. And you will think, okay, the fluid has been lost, let me administer fluids. And you are giving fluids, but the problem is not fluid. The problem is the vascular tone. If your vessels doesn't constrict, it is not going to pump the blood more strongly. And you are going to load it with the fluid, then what will lead? Ultimately, that extra fluid will ooze off from the vessels, and that will go and collect in the third spaces, lungs, ARDS. In the abdomen, you will get ascites. So then the patient is going to drown in his own fluid. So that is very dangerous. You have to identify the injury. You have to know what kind of trauma the patient is having, and then accordingly you have to act. So history is very important to evaluate and manage the patient. So just quickly I will go through neurogenic shock. See, the loss of vascular sympathetic tone, okay? The sympathetic tone is what it maintains, and that sympathetic chain is from T1 to T6. So if anything damage is a closed injury or a blunt trauma to the spine within that region, you have to be careful of that. It is not always a hypovolemic. Suppose you get a trauma patient and the patient is showing features of a class 2 shock with a reduced BP, with an increased heart rate, and you are thinking that is of hypovolemia, but you are not thinking of this, then it is trouble. Then you have to give vasoconstrictors, you have to give atropine, you have to give adrenaline, some vasoconstrictors to increase the sympathetic tone you have to administer along with the fluid. If you just give fluids, then it's a big trouble you are calling for. Okay? So let's come to the stages of shock. Now we have done all the kinds of shock. So for you guys, in orthopedics, most important 3 things: hypovolemic shock, then you have the septic shock, and the neurogenic shock. 3 types. There are other 2 types of shock also: anaphylactic shock, cardiogenic shock. Cardiogenic shock you will deal in medicine. Definitely you will read it in the final year. And anaphylactic shock, you know what to do. Many of you already have. You will take steroid, hydrocortisones, shots. You have EpiPens. Now EpiPens have come. Epinephrine pens, right? EpiPens have come. So how many of you have watched a Good Doctor series? Good Doctor? No one. So you will see that anaphylactic shock coming very often. In US, they have EpiPens ready. Anyone who has a tendency for a allergic condition, so they have EpiPens. So that will be like, you just push it and then it will come off. So stages of shock. So stages of shock. So there is an initial phase where it is a condition that it will come back. So an initial non-progressive phase, a progressive phase, and an irreversible phase. Okay? So these were the phases I am telling. So the net effects you have to know. There is an increased heart rate. There is a tachycardia. There is peripheral vasoconstriction. That's why you have cold, clammy extremities. There will also be a peripheral pooling of blood and renal conservation of fluid. So because the fluid has already gone, your kidney will try to preserve more fluid, and that is what is called renal conservation. That means the urine output will be low. That's what is meant. So all this results in a restoration of circulation and tissue perfusion, but that will go up to a limit unless you are doing something to revive the patient, or unless that insult has been stored. I mean, if the blood is getting lost, you have to stop that blood loss somehow. Then only the body will try to repair the damage. Otherwise, it is going to go on, and then you are going to lead into a multi-organ dysfunction. So an initial non-progressive phase, so that was the, I was telling about, baroreceptor reflex. There is a activation of the renin-angiotensin systems. So these are all physiologies that you have read in your first year. Okay. So that is how you get your body tries to preserve, or body tries to, improve what has been lost. Okay. So in this phase, a variety of neurohormonal and hemostatic mechanisms helps to maintain the cardiac output. Includes the baroreceptor reflex, release of catecholamines, the activation of the renin-angiotensin axis, ADH release, and sympathetic activation. Progressive phase. This progressive phase is a condition where your system is, or damage is still going on, and you have not still intervened. Okay. So in this phase, the compensatory mechanism fails to restore the circulation. The vital organ shows the effects of hypoxia, and there is a persistent oxygen deficiency. that leads to intracellular anaerobic glycolysis with lactic acidosis. All this results in reducing cardiac output and anoxic injury to the endothelial cells, and this leads to a formation of a DIC. And the last stage, once the DIC is established, it comes to a stage of an irreversible damage where the compensatory mechanism or therapeutic intervention has failed to restore the circulation, and there is a widespread cell injury. Widespread cell injury is reflected in the lysosomal enzyme leakage, nitric oxide reduced myocardial contractility, acute tubular necrosis. Actually what they mean is a multi-organ dysfunction. And when your different organs starts to fail, it is very difficult to revive the patient. That's what is there. So morphology of a shock, what happens? So since shock is characterized by the failure of multi-organ system, the cellular changes starts to appear in all these organs. So in brain you will see an encephalopathy, ischemic encephalopathy. Heart, there will be a coagulative necrosis. Kidney, you will see acute tubular necrosis. Lungs, in a diffuse alveolar damage and lung shock. GI, there is hemorrhagic enteropathy. Adrenal glands, there is a cortical cell lipid depletion and liver fatty changes. Okay? So these are just for theoretical purposes, but the basic thing what you guys need to understand from the concept of shock is whatever I have told from till now. So the clinical presentations are altered mental status, restless patient, pallor, increased sweating, cold, clammy skin, pulse will be tachycardic, respiration, tachypnea, increased respiratory rate, blood pressure becomes low, and dehydration with reduced urine output. Important part, how to manage a patient in shock. So, because you guys have missed the ATLS guidelines, so ATLS has given a very clear guideline on how to manage patients. So that starts from A, B, C, D, E. I will show you from the last slide. But from here, what I want to show you is ensure the ABC. What ABC stands for, you have to ensure there is a proper airway, that the patient is breathing. B stands for breathing. You have to see how much is the respiratory rate, whether it is tachypnea or tachypnic or not. And C for circulation. So you have to see the proper circulation is also happening or not. So you have to give certain drugs to increase vasoactive agents like dopamine and all you have to administer. Surgical intervention, suppose if there is a continuous blood loss, you have to do certain surgical intervention as well. So the prognosis of shock is that the prognosis varies with the origin of the shock and its duration. So if the shock is of early stage, stage 1, stage 2, it has very good prognosis. Young patient, good prognosis. Now if it has gone beyond stage 3 and 4, it is very difficult because it depends upon a lot of factors. Nutritional status, the age of the patient, the immunocompromised, whether it's immunocompromised or not, that is an important thing. But the most important thing I want to show you is that 80 to 90% of young patients with hypovolemic shock will survive. But which is more dangerous is a septic shock. Majority of the patient, when they enter into a septic shock, have a very high mortality rate, and that is almost up to 75%. So you have to identify the types of shock and act accordingly. So this is the last slide that I want to tell you because you guys have missed the class for the ATLS. So ATLS stands for Advanced Trauma Life Support System. Okay. So the main thing that I want you to understand is that the ATLS algorithm is A, B, C, D, E. So A stands for airway. So you have to maintain the airway. B stands for breathing. C for circulation, D for disability, E for exposure. So everything is self-explanatory. See, it has been given on the right side. So you have to see whether the patient is conscious or unconscious. Breathing, if you have to see whether there is any injuries to the chest. Circulation and hemorrhagic control, whether there is any closed injury to the abdomen. So there is something called FAST. You have to do a USG in the 5 seconds and then you have to see. And disability, you have to see like whether the reflexes are there, whether the patient is in shock. I was telling about the spinal shock. So you would say, check the reflexes, you check the sphincter reflexes are there or not. So that is a separate topic that we can come sometime later. But what is important is that from the ATLS is you have to maintain this A, B, C, D, E. Okay? Any doubts?